Hello and welcome to Cure Talks. I'm Priya Menon, your host. Today's show is part of our Innovator series where we discuss breakthrough treatments and research. The topic for today's discussion is treatment advances in Waldenstrom's macroglobulinemia. Joining us on the panel is Dr. Larry Anderson from UT Southwestern Medical Center, Dr. Rachit Bas from Moffitt Cancer Center, patient experts Meg Mangin and Peter DeNardis. Welcome to Cure Talks, everyone. Doctors, between me, Meg, and Pete here, we have quite a few questions. So I'll start with mine first and then hand over to the patient panel for theirs. My first question, Dr. Anderson, is to you, so that we get some basics straight before we get into deeper into the discussion. What is Waldenstrom's globulinemia and what causes the condition?
Yeah, great question. So I'll give a little primer answer on this. So Waldenstrom's macroglobulinemia, often referred to as WM or sometimes Waldenstroms, is a rare cancer of the bone marrow and lymphatic system. It's a subtype of non-Hodgkin's lymphoma, but instead of starting from a regular B-lymphocyte like most other lymphomas, WM cells come from a lymphocyte that's in partial differentiation state between a lymphocyte and a plasma cell. So WM is sort of like an overlap or a cross between lymphoma and multiple myeloma, in which multiple myeloma is a cancer of bone marrow plasma cells. So WM shares some of the treatments with both of those disorders. And also because these cells are in between a lymphocyte and a plasma cell, they're often called lymphoplasmacytic cells. And another name for WM is lymphoplasmacytic lymphoma. So you'll hear that term, or otherwise known as LPL. There are some versions of lymphoplasmacytic lymphoma that make a different type of protein from Waldenstroms. So they're not all the same, but Waldenstroms fits under the lymphoplasmacytic umbrella. The WM cells, however, are known for making a certain type of protein called immunoglobulin M or IgM, and usually in large amounts. And this protein is also known as macroglobulin because it's 5 times bigger than an IgG or immunoglobulin G made by myeloma cells. And so it's a lot larger protein or macroglobulin. But all of the IgM made by these Waldenstrom cells is of the same exact size. And so it's referred to as monoclonal protein or M protein. And the buildup of this protein in the blood in the patient can lead to sludging of the blood, known as hyperviscosity, in which the patient could have bleeding problems or visual disturbances. It could cause nerve damage. It can cause stroke-like symptoms. So hyperviscosity is one possible symptom. Many of these patients, however, present with symptoms of crowding of their bone marrow with these Waldenstrom cells. They crowd out the normal cells and cause anemia or low immune system, therefore increased risk of infections. And only about a quarter of the patients with WM will present with enlarged lymph nodes and spleen, which is different than most other lymphomas. WM is only diagnosed in about 1,500 patients per year in the US, typically between the ages of 60 and 70, with an average of about 65. And less than 1% of patients are under 40, although we certainly see it. And it's often slow growing, and we do have many treatment options. And so these patients often can have quite a long survival, but right now it's not a curable disorder with the current therapies, even though we can control it for many years. And the next question is what causes Waldenstroms? Now, we don't really know. There's no specific cause known for Waldenstroms. However, it does often arise after patients have a precursor condition known as IgM-MGUS or monoclonal gammopathy of undetermined significance. Possible risk factors include male sex, Caucasian race, increased age, family history of Waldenstroms, presence of chronic hepatitis C or HIV infections, and possibly exposure to certain chemicals. Waldenstroms is twice as common in men as women and more common in Caucasians than other races. There is a familial predisposition of Waldenstroms, in that about a quarter, 20 to 25% of patients with Waldenstroms will have a primary relative or first degree relative with some sort of B cell cancer, either Waldenstroms or lymphoma or myeloma. But there's not really a genetic mutation that we can test for to see if their family is at risk at this point.
Okay. Dr. Baz, I would like you to add to general understanding. What is the current frontline treatment for WM?
Yeah, I mean, I think the main thing is that there isn't a one specific treatment that's going to fit all the patients. And I think a lot of the choices for frontline therapy will depend on the patient's characteristics, what is the indication to treat, and whether there is an indication to treat in the first place. So a lot of patients who are asymptomatic may be observed without receiving treatment. Mm-hmm. For those who do need therapy, then the only approved agent currently the two only approved agents in the US are ibrutinib and zanubrutinib. However, that's not the only therapy for Waldenstrom, and sometimes, especially in older patients, we may elect to think about other therapies as a first line and reserve those agents for subsequent lines of therapies. And then there are some specific features on the presentation, whether it's magneuropathy only or whether it is mild anemia, how high the IgM level is, that can help guide the treatment discussion. But some of the agents that have activity include CD20 antibody called rituximab. Some of the agents that have activity include alkylating agents. We talked about the BTK inhibitor, ibrutinib, zanubrutinib. And then there is proteasome inhibitors that have activity at times. So there is a number of different therapies that one can consider. I don't think there is one standard approach for everybody in the first line setting, but a lot of it will depend on what's going on with the patient.
Oh, thank you. Thank you so much for that summary. Meg, you are a WM patient, so it would be great, if you could share your Waldenstrom's treatment journey with us.
Okay. I was diagnosed in 2016, and my first treatment was Imbruvica or ibrutinib. Mm-hmm. I was in a clinical trial, the trial for naive patients. It was working very well for the first 3 months. But then, unfortunately, I got some liver enzymes elevated, and they just wouldn't go down. So I had to stop the ibrutinib. And when I stopped it, I got a massive increase in IgM, probably tripled what I had to begin with. And I ended up having plasmapheresis to get that down so I could start on bendamustine and rituximab. That I had for 4 cycles, and it worked very well. And then I did go on maintenance for 2 years with rituximab. And that ended in 2019, in August. And I have been in remission, so to speak, since then. Numbers are good.
That's awesome. That's great.
Yeah.
Peter, what about you? You were diagnosed at the age of 43.
What were the one of those abnormal young people that get Waldenstroms. So at least I broke the 40-year barrier when I was diagnosed. But I was heavily symptomatic at the time and was treated with probably things that are not used so much for frontline at the time. I'm treated with fludarabine, cytotoxin, and Rituxan. Got a good 5 or 6 years of remission out of that. And my IgM was very high when I was initially diagnosed. It was around the 6,000 level. And I had all the classic symptoms, but then I had a relapse, and it was an unusual relapse. It was multiple things that were occurring at the time. And so I was treated again, but it was more to treat not only rising IgM numbers, but also a mass right below my spinal column that ended up being lymphoplasmacytic lymphoma cells. And so I'm one of those soft tissue tumor kind of people that have Waldenstroms, and that's another unusual occurrence. So we consulted with some experts, and my local hematologist had the right plan, which we did high dose Cytoxan, and some Rituxan, some dexamethasone, and also radiation to the location of the tumor. And then, so that was, maybe 10 years ago. And about maybe around 2016, 2017, the mass, I started to have some pain. And so they thought it was a classic, what they call schwannoma. It had all the ear markers that it was benign and everything else. So when they went in to surgically removed it, they said, oh, yeah, let's test that. It's lymphoma cells again. And sure enough, it was the LPL. So we just treated it with that surgery, and where it's located, it's not a good spot to try and, yank it out of there any further. So we did some local radiation again. And since then, I've been on ibrutinib for the past 2 years, a low dose to possibly keep that in check. And we're just keeping an eye on it via PET scans. And so far, I can't complain. Since 2010, my IgM has been virtually non-existent. All my immunoglobulins are pretty much wiped out. So I am an unusual case, but I've seen just about everything so far. So hopefully that's enough. And I'd like to keep it that way. So in the meantime, I have been working with the IWMF and volunteering because they've been a great resource for me. So I wanted to return the favor.
Thank you. Thank you for sharing that, Pete. So I'm going to circle back to Dr. Anderson and talk about the novel drug CLR-131. Dr. Baz, I would like you also to chip in on this. So Dr. Anderson, can you give us all some background on this drug and the result of the clinical trials, and why do you see this as being very important?
Yeah, great question. So CLR-131, it's an investigational cancer therapy. It's known as a phospholipid drug conjugate, or PDC. It really takes advantage of this selective uptake and retention of phospholipid ethers, or PLEs, by cancer cells compared to normal cells. And they have these higher concentrations of lipid rafts on the surface of cancer cells compared to normal cells that allow the uptake of drugs that are conjugated to those phospholipid ethers. And CLR-131 is an example of this. It's designed to provide targeted delivery of radiation from iodine-131 to malignant cancer cells, and therefore minimizes radiation exposure to normal tissues. The reason it's exciting in Waldenstroms is because there was some data presented at the American Society of Clinical Oncology meeting, or ASCO meeting, this year in 2021 by Dr. Alawadi et al. And they showed that out of the first 6 patients with Waldenstroms treated with this compound, 100% of them had a response, and they responded to the treatment. And so that's very exciting. And it's really the ability of this first-in-class drug to work in Waldenstroms, that it appears to be independent of other, whether they're sensitive to chemotherapy or immunotherapy. And it doesn't seem to matter if the patients have a different genotype or gene mutation status of their genes that we call MIghty88 and CXCR4, which do make a difference with other therapies like the BTK inhibitors. So that kind of sets it apart. And some of the preliminary findings that were presented were that, out of these patients that responded, 83% of them were previously treated with rituximab combinations, and 100% were either refractory or had a suboptimal response to ibrutinib. So if patients do start to relapse after BTK inhibitors, these trials would be a good option. And basically, they've also shown data that the Waldenstroms cells have even higher concentration of these lipid rafts compared to other B-cell malignancies, which makes it particularly better in Waldenstroms potentially. And what they saw was that there were really there were side effects. Most patients had low blood counts, either low white blood cells or red blood cells, but generally manageable. And as blood cancer doctors, we're used to taking care of those side effects with most therapies. But fortunately, they did not see deaths from this. They did not see heart, liver, kidney, eye, neurologic toxicities that we worry about. So those were not seen. And based on the results of this, We're now doing a phase 2 kind of global pivotal phase 2 study, a registration study that's seeking to enroll about 50 more Waldenstroms patients with relapse disease.
Dr. Baz, what about, it'd be great if you could talk a little bit about the mode of administration of this drug and dose schedule, the optimum dosing, as well as probably, the durability, or what is the responses, how durable are the responses?
Yeah, I mean, I think, Larry covered the mechanism of action very nicely. It's, this is a phospholipid drug conjugate. So, the radioactive iodine is delivered to, the cancer cell by virtue of the fact that the cancer cell express more of those lipid raft that can internalize the, phospholipid drug conjugate. And irradiation, is an effective treatment for lymphoma, Waldenstrom in particular. So that would be one way of, tumor cell killing. What I find particularly neat about, CLR 131, it's a finite treatment duration. If you think about BTK inhibitor, for example, patients have to keep taking the medicines for, very long periods of time, which usually means, that the drugs are effective for long periods of time. But, as has been the experience for one of the panelists, once you stop ibrutinib, there's a lot of times there's a flare in the IgM levels, and it can be a little bit hard to manage. So, ibrutinib and BTK inhibitors work very well for as long as the patient takes them. Generally, the acquisition of resistance to BTK inhibitor is, it happens in Waldenstrom, maybe less likely than it happens in other conditions like CLL, but it itself, becomes, a challenge with time would be the tolerance, the tolerability of those agents long term. So the neat thing about CLR 131 is that it's given in 2 cycles. Each cycle is comprised of 2 infusions. The cycles are about, 56-day, type of duration. And that's it. And after that, the patient's on observation. And the data that, Dr. Ailawadi presented at ASCO suggests that the responses are durable. Now, it's hard to assess when you're talking only about the experience of 6 patients, but a lot of the responses are still holding. There is a patient that was almost 3 years out and still benefiting from treatment. So I think this is all very encouraging. And I think really this is the neatest part of therapy in my mind, is that you have a treatment-free interval, which from talking to a lot of patients is what patients probably value the most.
Absolutely. So I'll just ask one more question before I let Meg and Pete ask theirs. Dr. Baz, can you briefly touch upon some of the other new drugs and treatments, that are being researched or studies for WM?
Yeah, I mean, so we mentioned BTK inhibitors. We also, mentioned, sometimes proteasome inhibitor, alkylating agent, CD20 antibodies, but there is more actually treatments that, can be considered. There is, treatments that is not approved for the conditions, but we could use off-label, including BCL2 inhibitor like venetoclax that would be used off-label. There is nice data in, ibrutinib intolerant or resistant patient about, venetoclax efficacy. There is clinical trial data with PI3 kinase inhibitor in combination with, CD20 antibodies. So I think there's a lot of reasons to be optimistic overall. I think given the number of agents we have to treat Waldenstrom, I think the therapeutic, armamentarium we have is going to keep growing over time. And that's great because we understand biology better. But some of the existing agents still going to be helpful, even, even years down the line, some of the older stuff and maybe less, cool stuff, so to speak.
Thank you, Dr. Baz. I'll now let Meg start with hers. Meg, all yours.
Okay. Dr. Anderson, you mentioned before that there's a familial aspect to Waldenstroms. My sister also has Waldenstroms, but her course has been very different. What I'd like to know is, what do I tell my adult children? How should they be tested, or if they should be tested, or what they should be looking for?
Yeah, so unfortunately, there's not a specific test that we can say, or when, what age should they start looking, or what testing to be done. I would just say, you know, especially if you have a family member especially with two members with Waldenstroms, what they would probably want to get, you know, with their yearly checkup, just a blood count and a chemistry panel. And if they have anemia or elevated protein, then they would warrant further workup to look for a monoclonal protein or evidence of Waldenstroms.
Okay, thank you. Dr. Baz, have you been working with pirtobrutinib? And if so, have you seen any success with that new BTK inhibitor?
I have not. There are a number of BTK inhibitors that you know, are in development, and actually, obviously, the three that are currently FDA approved, so to speak, you think about acalabrutinib, zanubrutinib, and ibrutinib. For the Waldenstrom indication, you know, mostly we're thinking ibrutinib, zanubrutinib, but the main mechanism of resistance seems to be a C481S mutation in the BTK gene, and there is novel BTK inhibitors that, you know, hopefully will, you know, be able to overcome that resistance in the future. Although this is still, you know, to be determined. There is a LOXO compound, and there is also, you know, vecabrutinib that we've worked with at Moffitt. But I think, you know, it's an interesting field out there in terms of, you know, further BTK inhibition and trying to overcome, you know, resistance and intolerance to the first generation, so to speak, of, you know, BTK drug.
Okay. Thank you. Dr. Anderson, when should Waldenstrom patients have stem cells harvested and preserved for future use?
Yeah, so great question. Stem cell transplant in Waldenstroms is more controversial lately because we have so many great other great options besides transplant. We used to do a lot more. We still do it, but we're usually reserving the transplant for kind of third, fourth, or fifth line or beyond. But we still, especially if a patient's younger and they want to preserve that option for a stem cell transplant later, we'll often recommend considering collecting and storing their stem cells. You know, maybe whether it's after first line or second line therapy. Mainly we want to do that before they've had too much bone marrow toxic therapy. So one of the ones that would be could cause bone marrow damage over time would be a lot of bendamustine. So if we do have a patient getting bendamustine, we'll want to consider collecting and storing their stem cells from their peripheral blood after, you know, 4 or at most 6 cycles. Probably not wait until after 8. Because they were going to decrease the yields of those stem cells. And, you know, but even if we collect and store, we may not use them until after another 1, 2, or 3 more lines of therapy, because the stem cell transplant, although it can be quite effective and is a good option, is going to cause a lot more side effects than, you know, the BTK inhibitors, the proteasome inhibitors, the bendamustine. And then we also have you know, allogeneic stem cell transplant is also a potential option for these patients, but generally, and that's actually the only potential therapy we have that could potentially cure Waldenstroms because of that donor immune system, but it has a lot of other toxicities with the donor immune system attacking the patient. And so we generally reserve that for patients who failed most things and that are younger. So it's not that commonly used.
Thank you.
Yeah, I would completely agree. I would add to this that, you know, there may be some subpopulation of Waldenstrom patients who maybe really should be considered for transplant, especially those who have, you know, for example, coexistent amyloidosis. That may be one of the, you know, co-indications. Some patients who merely have light chain deposition disease. Well, basically where there is really a need to achieve a complete response hematologically. A lot of the existing Waldenstrom therapy can do quite well, but complete responses in Waldenstrom remain uncommon. And I think because of that, transplant can get us there, and that could be a valuable tool. So for the right patient, absolutely, although the data is limited because of the fact that Waldenstrom is not a very common condition. And a lot of the data ends up being case series and, you know, and smaller publications.
Thank you. Dr. Baz, when is CAR T therapy appropriate for a Waldenstrom patient?
Well, I mean, currently CAR T is not approved for Waldenstrom specifically, although there may be an approval for, when you look at transformed lymphomas, they could be appropriate for CAR T therapy and, CD19 CAR. And obviously, Waldenstrom can sometimes transform to an aggressive lymphoma. And there is, I think, a publication where one such patient received a CAR T for a transformed Waldenstrom and had done quite well. And I think so as a technical aspect, currently it would be part of clinical trial. Also, because of the relatively uncommon nature of Waldenstrom, I think I'm not aware of any trial specifically looking at Waldenstrom for CAR T. However, some of those trials are looking at many different types of lymphomas, and often indolent non-Hodgkin's lymphoma would be lumped into one clinical trial, and there may be a Waldenstrom subset that could be treated potentially. But I think likelihood is that CAR T would likely be a very effective therapy for Waldenstrom. What we need to consider is, one is that a lot of patients could do quite well, often without needing CAR T. Two is that a lot of patients with Waldenstrom could be of older age, and CAR T in terms of risk benefits may not be the best option for them. But once you think patients have had 2 lines of therapy, have become intolerant or refractory to BTK inhibitor, thinking about a clinical trial or a CAR T clinical trial specifically, I think would be certainly reasonable in the appropriate context.
Okay, thank you.
And I completely agree. I just want to also point out that what we don't know with Waldenstroms, especially in patients that have nerve involvement, might also have more side effects from CAR T cell therapy, with some of these showing, neurotoxicity and some of them showing other nerve damage. And so it might be something to, really study in trials before moving forward with patients with a lot of nerve issues from their Waldenstroms.
Mm-hmm. Okay, thank you. Dr. Anderson, are bispecific antibodies being developed to treat Waldenstroms?
So it's really in the same discussion as the CAR T cells. We don't have necessarily specific trials that I know of for Waldenstroms, but a lot of bispecific antibody trials include low-grade lymphomas that will allow Waldenstroms patients and similar patients on there. Most of these target CD19, which is expressed on, Waldenstroms, or AKA lymphoplasmacytic lymphoma, just like other B-cell lymphomas, and should work well. There's not necessarily a trial, though, dedicated to just Waldenstroms that I know of, though.
Okay, thank you.
Thank you, Meg. I'll pass it on to Pete next. Pete, you can ask.
Thank you. Okay, I'll see for Dr. Anderson. Given the promise of all the newer agents, all the new NIBs that are out there, do you foresee a time when the classic cytotoxic chemotherapy agents would no longer be utilized? Things like bendamustine, Cytoxan, are they going by the wayside?
Great question. I mean, we do have a lot of less toxic therapies now, but I think they still have a role. So patients that need a really rapid response, that are having hyperviscosity and in the hospital, and they need something right this minute to get their Waldenstroms under control, right after their plasma exchange is done. A lot of times we'll go ahead and start them on bendamustine. There is some possible role there for the BTK inhibitors that can also have a fairly rapid response. But then you usually have to wait a week or two for insurance approval. You have to figure out what the copay is, figure out if you need copay assistance. And so if a patient's sitting there waiting with hyperviscosity, you can't really wait on those things. I don't think it will completely rule out the need for alkylator therapy just yet. But yeah, so it might get there.
Okay.
I will add that, the really neat thing about alkylator therapy actually is the fact that, patient could have a treatment-free interval. And I think this is something that, is very important. And then the last point is obviously, something that Larry hinted to is the cost of therapy. BTK inhibitors, very expensive. Alkylating agents have been around for a while, relatively cheaper. And so when you think about a finite treatment course, say 6 cycles of whatever, versus, long-term ibrutinib or the like, I mean, certainly that can have a very different financial impact. And there are patients, obviously, finally, who, despite all of the availability of those agents in the United States, copays are very high, and we talk about financial toxicity with those agents.
Thank you.
Yeah, and I agree. And I think, another point is, just like you mentioned, even if I thought a BTK inhibitor was very appropriate therapy for someone, they got it for no copay. A lot of patients, they don't want to be on therapy for the rest of their life. And so they just want to say, okay, what can I do with the least amount of time on treatment? But then other patients may come in and they have, they may live 2 or 3 hours away. They may not have good transportation. And so, all of our infusions that we have that we may be recommending, they may not be able to come in that frequently or not want to do an IV therapy. And so then oral, it's good to have both options, basically.
Great. So you actually answered one of the questions I was going to ask, and sort of indirectly. I was going to ask, what factors should a newly diagnosed patient look at when they're trying to decide what treatment to undergo? And sometimes when I've talked to my hematologist when I'm having a relapse, I said, "Well, which one do you want?" Well, how do I know? So, I guess it's a number of factors.
Yeah, it's a whole list of things like, like I said, how far do they live? Do they have transportation? How fit or functional is the patient? Do they have bulky disease that needs to get, under control right this minute? Do they have a preference? All of these things come into play. What is their copay assistant? Do they have prescription coverage? All of these things can have a big impact on their treatment.
Yeah, I agree. I think it's definitely a long discussion between the doctor and the patient that will ultimately come back with a more of a personalized decision. I don't know that we can really, think about a cookie cutter approach for everybody.
Yeah.
Okay, thank you. This one, I guess, could be for either of you, but I'll start with Dr. Baz. Given the novel therapeutic agents that are coming out there, are there any that you see maybe have less of a side effects than others? Because even with the ibrutinib, there are certain side effects that patients get, hypertension and other issues like that. Is there anything out there that maybe is coming in the pipeline that will have, not only will treat the WM, but won't cause something else that you have to deal with for the rest of your life, potentially?
Yeah, I mean, I think this is, obviously the easy answer is there is no free lunch, so to speak. So there is not a therapy that's going to be devoid of side effects. But there is always this kind of a risk-benefit discussion on, what makes the most sense. And obviously, some patients who are at higher risk for, say, atrial fibrillation, you're going to take that into consideration when you're thinking of BTK inhibitor. On the other hand, when you're thinking things of the sort of venetoclax, it's generally well tolerated, but some patients will have issues with cytopenias. When you think about rituximab, which tends to be a very fairly well tolerated agent, some patients will have allergic reaction and still trouble receiving the agent. So overall, a lot of the therapies that we just talked about are generally considered to be, quote unquote, well tolerated. And most patients tend to do very well with them. BTK inhibitors are a prime example of that. There's a small subset of patients who have tolerability issue, but I think as a whole, I don't know that there is a therapy that's going to be devoid of side effects, but I think a lot of those agents have manageable side effects. And I think a good discussion with the treatment team can help kind of navigate those the best.
Thank you. Dr. Anderson, do you want to add anything to that? What are your thoughts?
Yeah, I mean, I completely echo everything he said. And I think, certainly I'm excited about bispecifics and CAR T cells for, not just Waldenstroms, but all hematologic malignancies. I think that does have the potential for hopefully getting patients in deeper remissions than we've seen with some of the other therapies, but it will come at some trade-offs at, risk of cytokine release syndrome and neurotoxicity. that could potentially be an issue for some of these patients.
Thank you. This one could be for either of you. I'll start with Dr. Anderson, then you can chime in, Dr. Baz. When I was first diagnosed back in 2003, I was told that I had to basically get my affairs in order, and I had maybe 6 or 7 years to live. And obviously they were wrong, but that's because of the advances in treatment since then. Do you foresee, what prognosis, if someone came to you now, newly diagnosed, what do you tell them? What outlook should they have?
Well, and I guess part of it depends on some of the risk features with that particular patient. That we look at things like, the tumor stage and the LDH and the beta-2 microglobulin and, how aggressive or how rapidly rising are their markers. All these things can help us give a better picture of what we expect. But in general, especially in someone that has the typical kind of slower growing Waldenstroms, we can definitely reassure them that we have many, patients that have had this for over 20 years. The average survival is probably somewhere in the 5 to 10 year range, but there's some data that at 5 years out, 75% of patients are still in remission, are still not having relapse for their Waldenstroms. And, even though we have all of these great treatments, a lot of these statistics haven't caught up with them yet. So even if you read a statistic from last year, it doesn't really reflect the FDA approved drugs that just came out over the past year. We needed a lot more time to see what effect that's going to have in the general population.
Thank you.
Yeah, I would add to this that, I completely agree. I would add to this that, I don't think we really know what is the expected median survival for patients diagnosed with Waldenstrom today. We don't know because, as Larry pointed out, agents that have been approved, this year or those that are going to be approved next year or next 5 years or 10 years are likely going to have an impact on the patient's outcome. So generally, I tell patients to be optimistic. I think statistics are very helpful when you're talking to groups of patients, not as much when you're talking to one individual. So in my practice, I've lost more patients with Waldenstrom to other things in life than to their disease itself. The patients we've lost to Waldenstrom, we've lost generally to transformed disease. And transformed disease tends to be very difficult to manage and treat. As a general rule, I think patients ought to be optimistic. I think patients generally do very well with this. And there is, despite that diagnosis, there is, a lot of reasons for optimism, especially nowadays.
Thank you. And to kind of key off of something you just mentioned about transformed disease. Now, granted, it's a small percentage of WM patients that get the transformation, but let's say if they transform to diffuse large B cell, which usually would happen, but are the treatments not there for diffuse large B cell, or is it because WM patients, being WM patients, they're harder to treat?
I think it's twofold. One is that, WM patients generally are older and, transformed disease treatment in an older population is harder. But as a general rule, when you even look at patients with CLL and transformed disease, where there is quite a bit more literature, the outcomes are still not good. And transformed disease remains very difficult to treat. Now, hopefully CAR-T will change some of that, but I still think, unfortunately, transformed disease remains hard to treat.
Okay, thank you. Okay, I think that's my questions. Yeah, I don't have another one.
Thank you, Pete. Thank you, Meg. I think there was some great questions there. Dr. Anderson, Dr. Baz, I have one question before we kind of wrap up for today. And this is to address the elephant in the room, COVID-19. So my question is it safe for WM patients to get the COVID vaccine given the immunocompromised condition? And are there any specific side effects that you're observing in your patients after getting vaccinated? Dr. Anderson,
I guess a couple points.
First.
Yeah, sure. Yeah, thank you. Yeah, so COVID vaccines and Waldenstroms, definitely will recommend getting those COVID vaccines and the booster for Waldenstroms patients. Now, certainly we do have information showing that Waldenstroms patients may have a lot lower response to the vaccines. That means they may not be as protective in Waldenstroms patients. especially if they're on active therapy with the anti-CD20 antibodies and BTK inhibitors. Those can significantly decrease the activity of the vaccine. But certainly if a patient's been off treatment for a number of years or they're smoldering, those patients should respond nicely to the vaccines. And then we do, see improvement after that third vaccine. Even if they hadn't responded very well with the first two, we can sometimes see boost. But what I would tell patients is, definitely get the vaccines and then act like you haven't had them, just because they may not work as well, but they're better than nothing. And what we don't know is, even if we can't see an antibody response because they're on treatment that suppresses antibody forming cells, they could still have a T cell response, and those T cells could still be somewhat protective against COVID. And as far as extra side effects, we don't really see increased risk of side effects in Waldenstrom's patients with the COVID-19 vaccines. We would see the usual, chills and aches for 2 or 3 days and sore arm, but not really anything else.
Dr. Baz, you want to add to that?
Yeah, really, there's nothing much to add here. I completely agree. I mean, I think obviously the vaccine may be less effective in this, patient population. However, they're particularly important, and a little bit of protection is better than no protection. So I think, Larry said it best: get the vaccine and act like you didn't get them. I think it is perfect. In terms of safety, we also haven't seen any safety issues. We looked at our own patients at Moffitt, not just with Waldenstrom in general, all hematology patients who received the COVID vaccine. And actually, it turns out they had far less side effects than the hospital employee that received the vaccine. So it may be that hospital employee complained more, but in general, it was pretty safe for our hematology patients.
Thank you, Dr. Anderson, Dr. Baz, Meg, Peter. I think this was a great discussion. Thank you so very much for all the information that you've shared. We are wrapping today's Cure Talks on Waldenstroms with an advice. So knowledge can be the best medicine of all. And when dealing with Waldenstroms, please do see a specialist. So with that, thank you, everyone. Have a good day.
Thank you.
Thank you. Take care.
Thank you.